Hi everyone, today we will talk about pemphigus vulgaris and bullous pemphigoid. To understand, first we need to talk about the normal skin. The epidermis of the skin contains epidermal cells attached to one another by desmosomes, and the basal layer of the epidermis is attached to the basement membrane by hemidesmosomes. Both pemphigus vulgaris and bullous pemphigoid are immune disorders, both being type 2 hypersensitivity reactions, whereby in pemphigus vulgaris, IgG autoantibodies form against the desmoglein 1 and desmoglein 3, both part of the desmosomes in the epidermis, causing disruption and separation of the epidermal cells, causing intraepidermal flaccid blisters. In bullous pemphigoid, the IgG autoantibodies form against BP180 and BP230, which are components of the hemidesmosomes, leading to the separation of epidermis from the basement membrane, presenting as tense subepidermal blisters. Here is a summary of what I just said. Feel free to pause the video or recap later. Now we will talk about each specifically, starting with pemphigus vulgaris. Recall I said the blisters in pemphigus vulgaris are flaccid, meaning that they burst easily. This is important in remembering two things. First is the patient might present to you with painful erosions, as you can see in the right picture. Second is remembering positive Nikolsky's sign, which just means peeling of the skin on minimal traction. This sign is also found in scalded skin syndrome caused by Staph aureus and in severe drug reactions like Stevens-Johnson syndrome. An important characteristic of pemphigus vulgaris is mucous membrane, which is rare in bullous pemphigoid. On histopathology, you can see the loss of intraepidermal cell-to-cell adhesions, called acantholysis, suprabasal cleft formation, and the tombstone appearance of epidermal cells. Another way to distinguish these two immunologic skin disorders is immunofluorescence. In pemphigus vulgaris, direct immunofluorescence shows IgG and C3 deposition in a reticular pattern, often described as chicken wire appearance. You can see how chicken wire looks on the right to help you understand. Recall that the Fc portion of IgG is capable of activating the complement system via the classic pathway leading to inflammation. Now let's move to bullous pemphigoid. Patients present with tense bulla or blisters. It's often found on flexural surfaces. Oral mucosa is rarely involved, and Nikolsky sign is negative because the blisters aren't peeled off easily. On histopathology, we can see the separation at the dermo-epidermal junction because of the hemidesmosome disruption. This is the epidermis here, this is the dermis, and you can see they are separated. Direct immunofluorescence in bullous pemphigoid typically shows linear deposition of IgG and C3 at the basement membrane zone. Indirect immunofluorescence may detect circulating autoantibodies against BP180 and BP230. When treating both skin disorders, systemic corticosteroids are the first line. They are combined with immunosuppressants like azathioprine, mycophenolate mofetil, and rituximab. Other drugs include tetracycline and dapsone. Pemphigus vulgaris has a higher mortality rate compared to bullous pemphigoid. Complications may include secondary infections, fluid and electrolyte imbalances, and ocular involvement. This is because of the flaccid blisters of pemphigus vulgaris that burst easily. Differential diagnosis for these two skin disorders include other autoimmune blistering diseases, such as dermatitis herpetiformis, linear IgA bullous dermatosis, and epidermolysis bullosa acquista. We can use histopathology and immunofluorescence to distinguish one from the other. This is a table to summarize the differences between these two skin disorders. Thank you for watching.